Hello everyone, this presentation will be about juvenile idiopathic arthritis. It's the first introductory topic to pediatric rheumatology and it's an important topic from examination as well as from a clinical point of view. I'll be presenting under the headings of the definition of arthritis, about juvenile idiopathic arthritis in general, followed by the criteria which are used for the classification of juvenile idiopathic arthritis, about the etiology, pathogenesis, the International League Against Rheumatology classification for JIA, the management as well as the prognosis. Arthritis is nothing but the inflammation of a joint characterized by swelling or effusion if two or more of the following features are present, namely limitation of range of movement, pain, tenderness, or increased heat. The term JIA was proposed by the ILAR, which represents a heterogeneous group of disorders which share all the manifestations. The ILAR is an international body which works and formulates guidelines for rheumatological disorders. Here you can just see an X-ray which depicts a 6-month-old child showing early changes. You can notice the soft tissue swelling present generally along with periosteal new bone. I will just highlight that. All this is soft tissue swelling in between. You can also see the periosteal new bone formations, which looks hyperdense here. It is seen in the second as well as in the fourth phalanx. Coming to the criteria for classification of JIA, the first point namely is the age of onset less than 16 years of age. The arthritis should be present in more than one joint, and the duration of the disease to be more than 6 weeks. This point is important because JIA becomes a DD for pyrexia of unknown origin. The onset type is defined by the type of articular involvement, namely polyarthritis if more than 5 inflamed joints are present, oligoarthritis if less than or equal to 4 joints are involved, or if there is a systemic disease where there is an arthritis with rash and it's characterized by a quotidian fever. The other thing is exclusion of all the other forms of juvenile arthritis, which I will explain in subsequent slides. Coming to the etiology of which, it is basically a rheumatological disorder in which it is because of the polymorphism of PTPN22 gene. It's because of the expression of TN alpha which is altered. It's associated with HLAs DR5, DR8, DR4, DW1. And HLA-B27 is very specifically associated with oligoarthritis. This is important from entrance point of view. HLA-B27 is also associated with ankylosing spondylitis. So from an entrance exam point of view, that is important. But as a whole, the etiopathogenesis is not fully understood. It is only based on a susceptibility theory and which is based on external triggers. So the exact pathogenesis is still not known fully. It is believed to, however, be because of a lack of autoreactive T cells, and the autoimmune disease is associated with alterations in both humoral as well as cell-mediated immunity. Coming to the basic investigations to be done for a case of JA, a complete hemogram is a must. This is to also include a peripheral smear as well as ESR. ESR is an important marker in JIA. Along with that, in general, we do a CRP for everything, along with ANA. X-ray of the requisite joint is important to identify the pathogenesis at a joint level. Rarely, synovial fluid aspiration is required for microscopy and culture, and bone marrow aspiration only in very severe cases. In most cases, the initial investigations itself is more than sufficient. So, the complete hemogram, peripheral smear up to an ANA and an X-ray is usually more than enough for investigating as well as treating a case. Coming to the ILAR classification, we classify it into systemic oligoarthritis, polyarthritis, which is further subclassified into RF negative and RF positive, RF being rheumatoid factor, psoriatic arthritis, enthesitis-related arthritis, and undifferentiated arthritis. Systemic GIA is where the arthritis is seen in more than one joint preceded by a 2-week fever, which is documented as quotidian daily for at least 3 days, accompanied by one or more of the following, namely serositis, which comprises of pericarditis, pleuritis, peritonitis, hepatomegaly and or splenomegaly, generalized lymphadenopathy, and an evanescent erythematous rash. The systemic pattern generally presents as a polyarthritis which affects the knees, wrist, ankle with extra-articular features of daily fever and serositis. So these two are important. The daily fever and serositis are important, and it accounts for 5% of all GI cases. There is no main predilection between male or female, it's affected equally. If we do investigations, the CBC is likely to show a picture which is suggestive of anemia. The total count will be elevated, ferritin will be increased if you do a ferritin assay, and platelet count also will be increased. This is the evanescent rash which I described in the previous slide. You can clearly make out the difference. The image is taken from Nelson's textbook of pediatrics, 20th edition. Coming to oligoarthritis, as the name itself suggests, the arthritis affects only 1 to 4 joints in the first 6 months, in which it is further subclassified into persistent or extended. When I say persistent, it means less than 4 joints are involved during the first 6 months. Extended means more than 4 joints are affected after 6 months. So 6 months is a cutoff time to classify it as either persistent or extended. The pattern of oligoarthritis affects the knees, ankles and fingers. The extra-articular feature is seen in 30% of all cases. What is important to note, oligoarthritis as a whole has a female preponderance, with females affected more than males 3 times than males, and it accounts for almost 30% of all GI cases. The investigations are more or less similar. What is important to note is ANA comes positive in 60% of all cases, with a mildly elevated ESR or CRP. In this picture, you can note a flexion contracture of the right knee with a prominent knee swelling. This is a clear-cut case of oligoarticular involvement with the right knee involved. Image is taken from Nelson's textbook of pediatrics, 20th edition. Coming to polyarthritis, as the name suggests, it affects more than 5 joints during the first 6 months. It's subclassified into RF factor negative and positive. If we consider RF factor negative, as the name suggests, if you do RF factor investigation, it will be negative. Female is to male preponderance is 10:1, and this accounts for 25% of all cases. The arthritis pattern in RF negative polyarthritis affects the small joints as well as the large joints, but TMJ has a preponderance, so that is important. It might be either symmetric or asymmetric, with an extra-articular manifestation of uveitis seen in 10%. Investigations wise, ANA will come positive in almost 40% of cases. The name itself suggests it's RF negative. ESR CRP will be mildly elevated with a mild degree of anemia. What is important to note, ANA will be positive in RF negative polyarthritis. This image shows the joint involvement in RF negative polyarthritis. It shows typical features suggestive of swan neck deformity, but what is important to note is there is a symmetrical involvement. Though it might be symmetrical or asymmetrical, this image shows a symmetrical involvement. Coming to RF positive polyarthritis, it affects more than 5 joints, and RF factor comes positive in 2 tests at least, that is greater than equal to 2 tests at least 3 months apart during the first 6 months. So to call it as RF positive, it should be greater than equal to 2 tests at least 3 months apart during 6 months. So to work up a case of RF positive, you need to work on the case for 6 months at least. This too has a female preponderance with extra-articular features of rheumatoid nodules present in 10% with a low grade of fever. Generally, this is more aggressive and it is more symmetrical. While RF negative could be either asymmetrical or symmetrical, RF positive is always a symmetrical involvement. Investigations wise, RF factor will come positive with elevated CRP and a mild degree of anemia. One point you would have noted by now, almost all the arthritis has a mild degree of anemia associated. This case X-ray which is shown is taken from Nelson's textbook of pediatrics. It shows how a prolonged disease process will result in joint destruction. You notice in the first case where the joint spaces are more or less maintained, whereas in the second case you do tend to notice the destruction, particularly at the proximal interphalangeal joint. Joint destruction is more prominent. Coming to psoriatic arthritis, it's an association seen between arthritis and psoriasis, the cause of which is unknown. If psoriasis and arthritis are both present in the patient, obviously it can be blindly labeled as psoriatic arthritis. You can also label it as psoriatic arthritis if arthritis is present with at least two of the following features, namely dactylitis, nail pitting, or psoriasis in a first degree relative. From an entrance point of view, the last point is frequently tested. Psoriasis in a first degree relative, you can think of psoriatic arthritis even if the child is apparently normal. It has a female preponderance of females being affected more than males twice. What is important to note, psoriatic arthritis is always asymmetric and the extra-articular manifestations of psoriasis or uveitis both are seen. Investigations wise, ANA comes positive in almost half the cases with elevated ESR, elevated CRP and a mild degree of anemia. The other features remain the same, but ANA is positive. The history and examination of the skin itself will suggest whether it is psoriatic arthritis or not. Enthesitis is a term which comprises of tenderness at insertion of a joint, insertion of a tendon, insertion of a ligament or a joint capsule. If arthritis is associated with this, it can be labeled as enthesitis-related JIA. Or if at least two of the following criteria are met, HLA-B27 positive, arthritis in a male child more than 6 years of age, sacroiliac joint tenderness or symptomatic anterior uveitis. It can also be labeled as enthesitis-related JIA. This is one of the only JIAs which has a male preponderance. Males do tend to be affected 7:1 as opposed to females. It affects predominantly the lower limb and the axial skeleton. The upper limb does tend to be spared, with extra-articular features of anterior uveitis and inflammatory bowel disease. What is important to note is 80% of patients test positive for HLA-B27. The management of JIA as a whole is multidisciplinary. It is not a single effort, it is always a teamwork. We have a pharmacological management which is accompanied by physiotherapy, occupational therapy, ophthalmological involvement which is done to rule out complications, identify uveitis early and give treatment. The ultimate aim is to prevent a lifelong deformity and to facilitate mainstreaming of these individuals and these children back into the mainstream so that they can go about their day-to-day activities as normal as possible. Pharmacotherapy is initiated with first line of NSAIDs. Second line we do use DMARDs and biological agents are now indicated. In NSAIDs, the first line which is preferred is naproxen at a dosage of 50 mg per kg per day with an upper cutoff of 500 mg given twice a day. Second line ibuprofen, though preferred as first line by some, is given 40 mg per kg per day with a maximum of 800 mg given thrice. Ibuprofen is still given most commonly at most centers. Newer NSAID use is meloxicam. Studies have shown it is quite effective at a comparatively lower dose. And all these three can be used in all subtypes of GIA. They are equally effective for symptomatic management. Of course, among the three, ibuprofen is preferred because it is most economically viable and it is most commonly available as well. Coming to DMARDs, the methotrexate is the first line choice in which the dosage is given as half to 1 mg per kg, either orally or given subcutaneous with a maximum of 25 mg per week. It does have its side effects of being hepatotoxic, so LFT monitoring is a must along with oral ulcerations commonly. The other DMARDs used include leflunomide and sulfosalazine. Leflunomide of course has its adverse effects of alopecia, though it is reversible once the drug is stopped, and it is also teratogenic at a higher age group. Sulfosalazine has an upper cutoff of 2 gram per day. We initiate therapy at 12.5 mg per kg and gradually increase it to 20, 25, 30, subsequently to a maximum of 40. But the upper cutoff can be given of 2 gram per day. But sulfosalazine is associated with GI upsets. It's known to cause hypersensitivity, and cases are documented where sulfasalazine causes Stevens-Johnson syndrome as well. In biological agents, infliximab is the one which is most commonly used. Apart from that, we do use etanercept and adalimumab as well. The side effects of all of these common side effects of the class as a whole include immunosuppression. There is a risk of malignancy. Studies are still ongoing, and there is also a risk for demyelinating reaction. Abatacept is an anti-cytotoxic T lymphocyte associated antigen 4 immunoglobulin. The name of the class of the drug is quite big, but the drug name is quite simple. It is given at 10 mg per kg per dose IV and is given only once in 4 weeks. The only side effect is an infusion reaction which causes hypotension. Anti-CD20 inhibitors is rituximab. It is the only drug which is given on the basis of body surface area. It's given IV once in 2 weeks, 2 doses. The most common side effect of it is an infusion reaction leading to hypotension, and it can also cause multifocal encephalopathy. We can also use interleukin-1 and interleukin-6 inhibitors. Interleukin-1 inhibitors, anakinra and rilonacept can be given. Between the two, anakinra is preferred. It is given subcutaneously, but it has to be given daily. It has a risk of injection site reactions and GI upsets, but it has comparatively less side effects than rilonacept. Rilonacept is also known to cause hypotension and is known for hypersensitivity reactions. Tocilizumab is given as a 12 mg per kg dosage once every 2 weeks, provided the individual is less than 30 kgs, or 8 mg per kg per dose if the individual is more than 30 kgs. It is hepatotoxic. I am sorry for the spelling error in the slide. It is hepatotoxic. It also results in cytopenia as well as GI upsets as well. What is important to know from an entrance perspective, anakinra is an IL-1 inhibitor. Tocilizumab is an IL-6 inhibitor. After these symptomatic drugs, glucocorticoids, that is the steroids class as a whole, is important. It is used in JIA where NSAID response is not seen. Among glucocorticoids, triamcinolone is the first line of choice. It is preferred in oligoarthritis, and it is preferred to be given through an intra-articular route only and only where NSAID response is not seen. Prednisolone is given at the rate of 1 to 2 mg per kg per day. It is given for unremitting arthritis and for other systemic manifestations also. Prognosis as a whole, it is difficult to control the articular and systemic manifestations for systemic GIA compared to others. It is also noted that in female children who are less than 6 years of age, they are at a higher risk of chronic uveitis if the onset of GIA is less than 6 years. Though as a whole, greater than 6 years is a criteria. If it is of juvenile onset, even amongst them, it is of a higher risk. These individuals also do tend to have active manifestations in early adulthood as well, and psychological adaptation might be required in GIA, and it also requires psychiatric counseling as well to ensure that they are mainstream and ensure that they are able to carry about their day-to-day life and activities. Before concluding this slide, I will only come back to the main classification of GIA as a take-home message. Ultimately, juvenile idiopathic arthritis is just the tip of the iceberg in rheumatology. The ILAR classification of GIA is important, which is why I am only going to stress on this once more. ILAR classified as systemic oligoarthritis. Polyarthritis is further subclassified into RF negative and RF positive. Psoriatic arthritis, enthesitis-related and undifferentiated arthritis are all the different subtypes. And I would like to reiterate upon one more fact before signing off. As far as the treatment is concerned, it is multidisciplinary and is always a team effort. I am stressing on the point of team effort because pharmacological management alone is not sufficient. Physiotherapy alone is not sufficient. Occupational therapy alone is not sufficient. It does require the involvement of a multidisciplinary approach to ensure that these individuals who are affected are brought to mainstream. On that note, I sign off. I thank you all for your patient listening. Thank you.